So I'm Sandy Jean Greco Brown, and I come from a pretty diverse background with healthcare. I actually started out more on the clinical side, and as a CNA and EMT doing documentation. I actually worked in the nursery and such at the small hospital that I worked at in Nebraska, and it was awesome. Taking care of babies, and it's a miracle I ever had children, honestly. After seeing childbirth and such. But anyway, I come today. Now I function in the role of coding and revenue integrity. And what that means is that I spend a great deal of my time trying to help people make sure that their documentation supports what they're doing, and that hopefully no one's going to go to jail, or that they, when they get audited, and if you haven't been audited yet, and you or your practice or your facility hasn't been audited yet, hang on, because it's coming. And we don't mean to scare you. We want to prepare you, and we want you to be prepared to be proactive. And so today we're going to cover a lot of information. We have 45 slides, but it's not that we're going to take up the whole time, but we do want to give you some great resources. And we tried to update this as best we could right before we had to submit it. So some of this, of course, we always know that this could have been updated since we turned it in, but please reach out to us if you have any questions. And I'll let Diane introduce herself and get us started here.
Very good. Good morning. My name is Diane Weiss. I am the Revenue Integrity Vice President for Restorix Health, and spent a good bit of time on both sides of the house, managing and being the medical assistant and office manager for a general surgery practice for about a dozen years. Then I went to the dark side and worked for a Medicare contractor for about 12 years. Then I came back to the provider side, but in a much different capacity. So the diversity works well with Sandy and I, and hopefully we've got a good, well-rounded presentation for you as it relates to understanding today's world of audits, which is quite comprehensive. Just real quick background here. Any of you guys caregivers? Or you guys more on the administrative side? More administrative side? Okay.
Just get a feel for.
Sure. So you'll appreciate the notion when we talk about not if you get audited, when you get audited. And what the ultimate goal of this particular session is to make sure that when you do get audited, you get to keep your money. That's kind of what we strive for in the world that we live in, and where we go from there. So what we'll start off with is just kind of an overview of those external audits. Obviously, today we want to make sure that you understand all the current audit activity, who's looking at what is what we try to talk about. And then we're going to share some ideas about best practices in keeping up and understanding how to respond, what to do when those ADRs come in. And when I worked at Medicare, we used to call those love letters. And we would get, in provider education, my boss would say, we've got a round of love letters going out, so be prepared for support and education. So again, we'll talk about the different types. We'll talk about responding, how to manage the whole process, who's on your team, or do you need to put another team together, or how does your team interact with the rest of the departments within your organization? And then we'll share some resources and take all your questions. So Sandy, you want to get us kicked off?
Absolutely, yes. All right, so today we're also going to talk about the different types of audits. And Diane and I, kind of work in different realms, but it's funny, we reach out to each other and I'm like, okay, have you seen any audits on the hospice front? Because we started to. So it's amazing where we're beginning to see audits. Just look out and you read anything, you can see there's so many different audits. So we're, like Diane said, we're going to just kind of talk through the process, but we want you to walk away with, gosh, these are some great tidbits of how we can be prepared and make sure that we're responding appropriately. And then, like we said, we'll have resources. We've tried to put a lot of links in here as well. And they were up to date when we submitted the presentation, so we hope that they are still up to date, but we can send you anything as well later. And then if you have any questions, and I know we are the next, that we're the thing that is between you and lunch, right? So it's better, I think, than being between you and the social hour, because I always feel like people are like, could you speed it up? Because I'm trying to get to that glass of wine. It's calling me. So we will definitely stick around and we have questions. And you can always reach out too if you get back and someone asks you a question or you say, oh gosh, Sandy, we don't know, or Diane, we don't know where to begin on how to set this up. Make sure someone is tracking your audits. And why is this important? You know, we'll spend quite a bit of time thinking and talking about this today, but it really is important. And we, like Diane said, we want you to be prepared. We want you to be cognizant that audit activity is going on out there, even if you're doing everything that you can and should be, and you're documenting everything appropriately, you're still going to get audits, whether it's private payers or it's commercial payers or it is our governmental payers. You're going to, unfortunately, get some audit requests, and they just want to make sure that the documentation supports what you're actually billing. There's a novel concept, right? So we want to make sure of that. And that's really, when we're doing audits, that's what we're looking for is, does the documentation support that? And it is frankly amazing to me how often I'll look at documentation and I'm like, I don't see the documentation for this. And then I may meet with them and I'm always, I try to be professional and they say, oh, we didn't know that code required that. Okay, well, first step, some education. Second step, yes. So we try to do lots of education, and we're going to talk about education as well towards the end of this. So with our racks, we've had these around. I remember way back when these started, they did pause due to the pandemic. I don't think they wanted to overwhelm all of us. We were already trying to care for our patients and such during the lovely pandemic. But you can see that there was a significant increase since then of some of the money that they have had to pay back, that people have had to pay back. And I keep reading, I'm just astonished at some of the information and the paybacks. I am just thinking, I don't know how you get to that point. Like, it's beyond my comprehension. So we just try to make sure that your documentation supports it. Just know that if you do feel like your documentation supports the RAC audit, and you are like, oh no, be sure that you do file an appeal, and there are different levels that you can file. So just be aware of that. Here are some examples. These they have different areas that they are auditing. We have the physician side, and they have just different areas. So be cognizant of those as well. Here's where medical necessity is huge. And I know that some folks are not comfortable auditing for medical necessity. They say, oh, I'm not a clinician, or maybe they are a clinician. That's where you really do need to get a clinician involved. If you don't feel comfortable, you need to be looking at these things. Here's some other examples for Medicare Part C and D, and these have carried over. These were the same things that they audited for in 2022, and they saw enough issues, for lack of better terms, opportunities, that they then moved these to 2023. Here's just the map of the different the racks here so that you can see this and the topics. So we put the links in here too. And I think it's helpful to just be able to see who is in charge of these and who do you need to reach out to. And then another thing that you want to be aware of is coding clinics and the CPT assistant articles. There are many of these, and I know not everyone here has a coding or billing background, and that's okay. We just want to make sure that those folks do have access to these different resources, and make sure that they're reading them, staying abreast of the new changes. We had new changes, and we have new changes coming out. Like we've all said, change is constant with healthcare, so we can just about, we'll have new codes. We have had lots of updates to these. I know that the immunization codes for COVID, are changing. They've deleted a lot, and now we're moving into the others as well. And then we have our MACs, our Medicare Administrative Contractors, and they are really trying to protect Medicare and make sure that the funds that are being paid out to pay for patients' care are actually appropriate funds, and that, again, the documentation supports it. And I don't know about all of you, but on LinkedIn and other entities out there, I see all the time of people committing fraud. And I think, oh my word, it's beyond my comprehension, but that's what they're looking for.
I've seen an increase in the Target, Probe, and Educate audits from the MAC level, where the Medicare Administrative Contractors said it was supposed to be a gentler way of providing us with education. But I think one of the biggest misconceptions is when you fail the first round of TPE, you still have to pay the money back.
We do want to talk about, and we'll mention the MACs and then the SMRCs. And we did add in here just so that everyone knows. I know I was talking to a client last week, and they said, we don't know what the SMRC is. And I said, oh, well, let me just share this information with you. You want to know, and you should be tracking this, because there is one national contractor, but they can audit across the board. And we'll look at this in just a minute. I've unfortunately been dealing with them in trying to help a client as well. And then we have our RACs and then other entities as well. As these are coming down, it's definitely a concern here. We also can have things coming from our CERT that we're going to talk about, that comprehensive error rate testing, the Office of Inspector General, so the OIG, and the Government Accountability Office as well. And then they also can be coming from the Medical Review and Education. So it's not good when these things are coming back to the MACs to then audit and investigate. As we think about the CERT error rate here and thinking about where they're going to be looking for these, this was originally created by CMS, and they were looking at those fees for service that were improperly paid. And what they were trying to look at is that error rate. And it's one of those things where your error rate may not be so bad that they say, oh, you're committing fraud, but it could be indicative that it's still incorrect. And that could be concerning. And I know sometimes people are like, oh, it's not that bad. And I'm thinking, oh, but it's not that good either. So let's think about that and how can we be able to handle this? So it can result in recoupments. So again, they can be taking that money back. And I think too often we hear of folks who they're like, oh, we got paid for that. Oh, we just put a modifier on that. We're not worried about it. And I'm like, gulp. That doesn't mean that you get to keep the money. And too often I see money having to be paid back. And that is not a good place to be.
There is, relates to CERT, one other piece about that error rate is that also impacts the MAC's performance. So is not only used to see if claims were paid correctly, CERT's also used to evaluate the Medicare contractor themselves. That error rate counts towards them as well. And then the error rate in general also speaks to knowing what the rules are, and that's how we feel. especially on TPE, is not published because they use varying pieces of information to determine how egregious that error rate is. So I've searched the program integrity manual. I've asked TPE educators, what is an acceptable error rate? And the answer will just be that it varies. So there is not a published error rate. And I think a good analogy in that we should expect a 0 error rate. So.
Yes. Yes. We also have the SMRC. So these are new, and these are where a lot of folks don't even realize that these are out there. And as we kind of mentioned a couple slides ago, they can cover Medicaid, Medicare Part A and B, and durable medical equipment. So they really kind of are overarching. And I actually have been dealing with some requests recently. I don't know if you all have read about the hospice programs that are being audited in, I believe, 5 states. And it is becoming kind of an issue. You want to make sure, again, and it's one of those things where does your documentation support it or not? And I was trying to help a client, and they were getting very defensive about things. And I just was saying, well, now it's too late. I mean, 3 years later, when they're coming back and asking for records from 2020, we're going to give them all the documentation, or you're going to, and we're going to hope and pray that your documentation supports it. Because if not, there's nothing you can do about it now. And I could go on and talk about when to do addendums and not. That is not when you do addendums. So let me just say that is not the time that you have providers adding in notes and such. No. And we could go on and on about that. So they do focus on the high utilization. They're also going to focus on the high dollar services as well. So just know that that is a concern. Noridian is the only carrier for this. So they're the only ones right now who are going to be sending those requests and asking for these records. So you want to make sure that you've got your team in place to be able to respond to these. I had a particular client who had to assemble their team, and it was kind of painful, and it was painful to watch. I'll be frank. So good times. So with the TPE, of course, we want to be submitting clean claims, right? We want things to be going out the door, to get paid, and keep the money. We don't want to have to ever pay the money back. And so according to Medicare and our folks, they say you shouldn't ever be on a TPE. If your documentation supports what you're doing, you shouldn't have an issue. Well, this is when they discover issues, and this is where you may then qualify in their regards. When they're looking at the data, this is where you could fall outside of that bell curve. When they're comparing you to the other folks around you, and I don't mean to pick on you, it happens. And it doesn't matter what specialty you are. If you're billing the highest rate or the highest amount, you're going to be kind of selected. Yeah.
Depending on the size of your practice, but it may give the appearance that you're a higher utilizer, and you may be a higher. It's not a problem as long as your documentation supports it. Same thing with, I have a lot of critical access hospitals I work with. Some have wound care departments and some don't. But when they're looking at wound care services, they're compared against all the critical access hospitals in that region who may not even be offering the same service. So it's okay. It's not that because you're considered a high utilizer, that in and of itself is not a bad thing. You're going to just be comfortable responding and providing the documentation and then successfully moving forward.
critically important to have the team and for the communication so that you're not brought in at round 2, round 3, EGADs, and that people know what is going on, that people are tracking and that we know, have these providers been selected for the TPE? What's going on? Because this particular practice that I'm working with, I think they had a couple providers, but nobody really knew. And like you were kind of talking about too, making sure the right people are pulling the documentation. And we'll talk about that in just a minute, because if you're not sending in the right info, you're not going to get there. So that's where when I do reviews, and I know when Diane does too, we try to give feedback in, hey, I couldn't find this in the record. And if you are giving electronic access or you're sending this to a payer, I don't care who it is, if it's definitely Medicare, did you download this? Did you provide the flow sheet? Did you provide this? Because if you didn't, I couldn't find this. Or because the patient was discharged before the nurse put in the stop times, I couldn't see. It appeared to me as if the medication was canceled. And so to me, that appears as if it wasn't done. So that, EGAD. So it's having those sorts of conversations and then giving that information. Hey, you need to make sure when you have a request that you are providing these pages, because if not, you're going to fail. And this is not good. Like setting yourself up to, fail. The TPE on the skilled nursing facility. So this is something too where these have just been released. So we want you to be aware of these. I don't know how many folks work in the skilled nursing facility, but be aware of these. And we actually have 2 slides here just for you to review. We also put in the links and such as well. So, and they're doing these on the skilled nursing facilities to try to educate them, because what they found is that the diagnosis coding there is not what it should be. And they're just not capturing that with the patient-driven payment model, or that PDPM services. They just have not been doing what they feel they should. So when they did an audit. Proactive audits. So we've talked a lot about this. This is where, Christine mentions it, looking at your bell curves, looking to see how do your providers or your practice or your facility compare to others. And then thinking about this, who are your outliers as well? Those should be the first providers that you're auditing. That's where your risk is. Thinking about, where are our highest risk. If they are billing almost always a high level, if they're billing a high level plus prolonged, no matter whether they're seeing the patient in the office or the hospital, wherever they are. I'm also thinking about COVID cases. This is something too, making sure that you are reviewing some of those as well. I think we got maybe a little lax, or maybe we just, I just don't know how to phrase it, but we got to clean it up. We got to make sure that we've dotted our I's, crossed our T's, and we have everything captured. I know we just did an inpatient audit, and I would say 75% of the cases that had documentation of the patient being exposed to COVID, they weren't coded with that code. And I was like, eek gads. Yes, it's a Z code, but it should be captured. Like, we need to be getting this data. And our best practice of what we would recommend is that you are looking at 5 claims, at least 5 claims per federal payer, per provider per year. So that's really where you want to look at that, and then determining what your accuracy rate that's acceptable would be. And you want to think about this as part of your compliance plan. And I know, Jennifer and Christine talked about this yesterday with the compliance plan, and that it is mandatory. So
I think it's important that this is also presented as something educational and supportive and not punitive within your
Yes.
own practices, within your own teams. I'm not here to get someone in trouble. I'm here to make sure we're prepared for when we do get faced with this. So I think that's an important part of the message to include as well when you're doing your proactive audits. We're just making sure we got the A game and that we're prepared. And this is not meant to, find mistakes and fuss at people. It is meant to be educational and supportive. So I think that's an important message to incorporate with your proactive audits.
And also adding on to that, that you may find a provider too, that once you are moving past the providers that are your higher risk, you may find those providers who are always billing the lower levels. We just want to stay under the radar. Well, you want to be right coding, not under coding, not over coding. You want to be right coding. So we want to be billing appropriately. So thinking about that. Legal audits, a couple of things that I want to just mention here. One is that you can have, of course, tips coming in on your compliance hotlines. Hopefully you do have a compliance program in place and you have a method, whether it's email or however it may be done, and that those can be phoned in, emailed in, whatever, and hopefully it can be anonymous to kind of protect so they don't fear retaliation. And remember, we cannot retaliate against whistleblowers either. That was a definite thing I saw recently, a conversation on LinkedIn as well. And attorney-client privilege. So one thing here that folks tend to get a little bit confused about. A couple things. One is that you cannot just do an audit and then at the end of it decide, oh, these results were terrible and we're going to put this under attorney-client privilege. Too late. Too late. Once the audit has already been done, everything's been discovered. So it's too late to do that. You need to have that attorney engaged ahead of time, and you need to be talking about that ahead of time before any kind of data analysis and auditing has been done. And I even take it so far as if I start an audit and I have I'm 5 cases in and I'm seeing a trend and oh dear, that's when I put my pencil down or I stop auditing. I pick up the phone. I don't put it in email. Oh my gosh. I call and say, I think we need to have a discussion. And I will then try to get the healthcare attorney involved, or I'll tell the client, you can make the decision here to either do this under attorney-client privilege or not, but I'm telling you, I think that there could be a potential issue here. Because I've looked at 5 cases, all 5 had issues, we may have a problem. And that may be then when they want to loop in that healthcare attorney. The auditor needs to be engaged by the attorney, not by, the client. It needs to be that engagement. So I just want to really call that out because I've had people who said, oh, we'll just mark it attorney-client privilege. And I'm like, no, you've totally, you've missed the point. You missed the boat. So we missed the boat on that one. So
why would we want to do an audit under attorney-client privilege? Yes, so it helps if we want or if we need, and if someone ever, talks about this or they ask you, the questions that you want to think about are we trying to protect the facility while we're doing this investigation and we're doing this audit? Thinking about this, that we don't want this to be discoverable, that this is something that someone else could discover, and that we want to be able to gather the data and be able to then do the payback. And we are doing our due diligence. That's also important to make sure, especially if you have someone internally, if it's a result of an anonymous complaint or a concern, or you have a whistleblower. You want to make sure that they can see that you are doing the right thing. And, I'm kind of a stickler about the right thing and ethical and integrity, and you can't ignore things that are being done wrong. You can't just say, oh, we're just going to sweep that under the rug and just not pay attention to it. Good luck. And,
yeah. And then that's when I'm like, and we're probably done. So yeah, because I will give you the report and I'll be signing off now, because it's something that from an integrity perspective, when I know that you owe money back, I'm not going to call the federal government and tell them, but it's something that we all need to be aware of. So all right. We just want to protect things. So modifier 25, as we know, we have heard a lot about this. This has been very much discussed, and it's something our commercial payers keep kind of threatening. And I know that they are reviewing records. Some are, we want you to fax the records, going old school and things like that. But we want you to be preventive. And one of the best ways that you can be preventive is to refer to the National Correct Coding Initiative, to the manual, where it talks about the modifier 25 example, and again, be proactive in auditing these services. Look to see when you're billing an E&M service along with a procedure, does your documentation support it? And if it doesn't, then educate your providers, and educate your providers, and audit and educate your providers. And we did provide a couple resources here too that we're aware of, in addition to the NCCI manual. So, and COVID audits, I think we have talked about this one. I think that this will be something forthcoming more and more as we continue to see another variant, more patient cases. And so this is something to just be cognizant of. And I'm going to turn it over to Miss Diane.
Our next two sections will focus on responding and managing audits. And basically, it's all one big topic. We'll start with a best conversation about how to respond to those audits. And when we talk about that, the first thing we want to know is who should be involved in your audit response. You're going to get additional documentation requests, i.e. the love letters from a variety of payers, primarily from Medicare, but we know they come from all of your payers. So who needs to be involved? Who's on your team when these come in? And is it, people from the business office? Is it your compliance department? So identifying the folks who need to be involved in the process is going to be first. Then you want to make sure you've got that process underlined and defined from a leadership perspective, so the audit response can be handled timely and completely. And responding to those audits is where we begin to see the first real challenge. So we want to make sure that we've got the overall process identified, and we'll circle back to that when we focus a bit more on managing the audit process. But this is where we want to go ahead and begin. Who needs to be involved? I've got an ADR. What now? And most of the time, our leadership, our providers, our clinicians want to know, well, why did I even get this? What's the reason? What triggered this? Have I done something wrong? And you guys mentioned a little bit earlier about being high utilizers, having more billable services in one type of procedure than others. A variety of ways that, or a variety of events that could trigger it. There could be abnormal coding and billing patterns, and often it is compared to your peers. Sometimes Medicare contractors, as directed by CMS, will get information that says, hey, you guys in Louisiana spent more on steroid injections than the rest of the states, so we want you to go look at steroid injections. So it might not even be anything specific to your practice or your providers or the care that you're rendering. It could just be based on the dollars that are being issued out for certain services. Indeed, it is although it needs to go into your thinking processes as you're preparing the documentation to reply. Importantly, to satisfy most of our providers, whether it's our doctors, our nurse practitioners, all of our clinicians, you want to quell the concern about why am I being asked for my documentation? What horror do I need to expect? And we want to kind of quell that. There's a lot of reasons, none of which are any actions or the care we provided. So that ADR is going to come in, and we want to be clear that we read it thoroughly. We look at it from the first date on the letter to the last person who signed off on it. And before you even start getting your charts or heading to the copy machine or hit the print button, you want to read that ADR thoroughly. It's going to tell you the provider. It's going to give you the dates of service, and it's going to give you an itemized list of the requested documentation. And typically they're numbered. They're numbered. And you need to make sure you've got something in your reply packet to satisfy each one of those itemized documents listed in the ADR. And sometimes number 14 is, I want to see a copy of the claim and I want an itemized bill. And a lot of times that's overlooked because they're like, well, I sent you a claim. That's what generated the ADR. But they want that included with the response packet. And of course, we know that by federal standards, we've got 45 days to respond. You're going to hear us say it now and then a few more times. Set your own internal clocks at 30 days. Set yourself with a 30 days. I'll tell you why that matters in just a moment. They should be, again, reviewed very closely and carefully for exactly what is being requested. They should all be logged and tracked. Who's getting them? Where are they floating around within your organization, within your system? We'll give you a few tips on that when we talk about managing the process. But we do want to record the date we responded, how we responded, who responded, and then eventually we're going to circle back and filter in one last piece of information, and that's the outcome, because we want to know the outcome of the documentation review. We want to make sure that the copies are kept at your facility, that whatever you submit, whether you submit it by fax, by snail mail, or by some portal, which is now the more common process, you want to make sure you've got that complete packet in your own hands. And as you're preparing that documentation, again, having someone familiar with that particular service, the clinician from that department, the coder who maybe was involved in it, understand exactly what is being requested. We've talked about requesting the histories and physicals, and do I need, a year's worth of H&Ps to be included in this documentation packet when I'm looking to support one particular data service? Correct. And so understanding what's being requested then helps to make sure that you're putting the most complete response together. And in some situations and for some services, you may have to go back and submit historical data or historical documentation. For example, I live in the wound care space, so I'm involved in a lot of HBO audits, which is at the top of a lot of payers' lists, a lot of wound care related. And to support hyperbaric oxygen therapy, I have to have 30 days of wound care. So I am looking very carefully at those ADRs to make sure I've given them the whole picture. And even though I'm giving you 30 days, I need all of this to support one dive, one date of service. So again, the preparer should have a pretty thorough, pretty good understanding of the service that was provided, making sure that they're comfortable that the documentation supports that service. And then as we begin to prepare the packet, we want to make sure that the packet is reviewed for clarity. It's reviewed for a logical timeline. We're going to actually have got a flow chart that we use. So we're going to make sure that if you've got a two-sided document, you copy both sides. We never send two-sided copies, never. Flip them over to make that two-sided copy into two single-page copies. You want to organize the documents in such a way that it describes the flow of the care, where I started with my patient and anything that led up to the service that's being audited. We want to make sure that everything is page numbered. And I want you to do that in ink, not pencil. I want you to number every page in your packet in ink. And then I want to make sure that the cover letter, if it's needed, if you feel like there may be a little bit of concern that you're not hitting the nail on the head, have your provider write a very brief, and I say brief, no more than a paragraph, so we don't lose attention. We want very simple, straightforward explanation. So a brief cover letter at your discretion from the provider. We want to make sure that as we're including external documents, lab results, diagnostic reports, that they're legible. How many times has this document been faxed, and is it blurry or crooked? Is part of it cut off? Check the quality of the information in your packet. If necessary, put a signature log with it. Make sure that the ADR is on top and that you've included the contact information for the folks in your organization who are going to be able to answer questions as it relates to that ADR. And again, set yourself for a 30-day timeline.
I think what we're going to do now, because we're at time, is that we'll go ahead and go to the last slide. Sorry.
I just want to touch one thing, if I can have just 2 minutes. I want to talk about tracking them, right? Because that was one of the main things about managing them. I'm going to give you this one list tidbit. It's about knowing what they look at. We've talked about PE, about racks, smirks, and reviews. This is nothing more than a pretty detailed spreadsheet. And we have folks on our team who look at every Medicare contractor's website. They post their TP. And you can see I have a column for in my headings, I list the contractor in column A. And then in B and C, I list the part A and the part B. And they're contractor going through a TPE audit, maybe looking at certain services on the facility side, but not on the physician side. So you can see very quickly that as you go through this, it's not sophisticated, but every month we update this and I share it with the 240 hospitals that we manage. And they know exactly what is being looked at under TPE. So you can do that proactive piece. The other thing about the SMRCs is they publish their topics as well. SMRCs publish it. And not only do you get to know what they're looking at, there's a project number. And if you click on that project number, it'll tell you exactly what they're looking for and why. And then when the SMRC project is completed, you can go back and look at their completed and it'll tell you the results of that SMRC project. The RACs also publish everything. So on my little external audit topic list, I have a tab for RACs. I can go to all those websites and I publish what's being looked at, who's looking at it, and even include the CPT or HCPCS codes. So you can know who's looking at what. We know that the Medicare contractors themselves, most have pretty much closed their med review pre and post pay, and they've either completely closed it or they've moved it to TPE now that TPE is back in its wisdom and glory. So I just wanted to share with you that managing those audits is actually pretty simple. There's a lot of published information. It's easy to get, and it doesn't take a lot of sophisticated software to manage it at all. It's actually quite simple to know who's looking at what, and then we update that every month. I would encourage you to adopt something similar, and then to use that for any education that you need to. Bring you down to.
Yeah, and actually, I'm just going to go to our last slide where we provide our contact information. If you should have any questions or anything, thank you all so much. We knew that we would have lots of good information to share, and thank you for staying the extra time and such. But please reach out if you have questions or you're having any challenges that we can help connect you with some resources. So